Chris or Daniela? Okay, excellent. Thank you so much for joining. Today we have two phenomenal speakers who are going to grace our seminar today, Dr. Jillian Pintye and Dr. Elvin Geng. They will go in series. Jillian will go first, and then we'll have a short hiatus where we will have some information related to one of our CFAR cores from Kenisha. So, but before that, I wanted to remind you that about what the CFAR seminar represents. The CFAR seminar is a forum for presenting and discussing state-of-the-art research findings in HIV pathogenesis, virology, care and treatment. And it's also meant to provide an opportunity for ongoing enhanced communication and multidisciplinary collaboration among HIV/AIDS researchers across the CFAR affiliated institutions and other partner organizations. So our next CFAR seminar will be on Thursday, April 7. So that aside, I'm excited to have my very close colleague, Dr. Jillian Pintye, who is a non-scientist here at the University of Washington, whose research does focus on HIV and STI prevention and treatment, particularly within maternal and child, as well as family planning settings. She's engaged in a suite of studies related to pre-exposure prophylaxis for HIV prevention among pregnant population and younger women in Kenya, including those related to clinical epidemiology, kinetics, as well as implementation science studies. So we are excited to have you, Jillian, speak to us, and you have the audience to yours. Jillian?
Sorry, here I am.
Oh, yes. Okay.
Move these boxes around here.
Okay.
And let me advance. Great. So I'm so excited to be here to discuss our research findings with you. But first, I want to thank this amazing team who I have the pleasure of working with. They all directly contributed to developing these slides and implementing the studies that I'm about to share. But I want to also give a special thanks to Julia Dettinger, who is personally responsible for many things CFAR, but especially these slides. And although I've worked on HIV in communities other than my own for some time, primarily in Kenya, I fully recognize that my perspective is that of an outsider academic. I also recognize how my positionality and privileges influence my perspectives. And our team's studies are among pregnant people who identify as cisgender women, but we acknowledge that the experience of pregnancy is not only among those who identify as cis women. And the other disclosure I have is that I was recently a pregnant person myself. And here's a photo of my husband and I and our baby back when we were less sleep deprived than we are now. That baby is now 6 months old. And this experience has really changed my own perspective on conducting research with pregnant populations and their infants, really in all facets, and how special it is to be involved in studies during this amazing transitional journey in participants' lives, for which I am very grateful. Now on to the content of this talk. HIV incidence is alarmingly high among young women in some settings and persists during periods of pregnancy. A study by Dr. Carrie Thompson using data from women, primarily in Kenya and Uganda, found that the per coital act risk of acquiring HIV was twofold higher during pregnancy compared to non-pregnant periods, which underscores the high risk for HIV observed among pregnant women in some communities. Newly acquired maternal HIV infections often lead to vertical transmissions. In these stacked bar charts of infant HIV infections, the orange bars show that almost 1/3 of infections are due to acute maternal HIV infection in pregnancy and breastfeeding. So prevention of new infections during pregnancy and breastfeeding is critical for both mothers and their infants. In 2017, the World Health Organization released recommendations that include HIV-negative pregnant women where HIV prevalence is high among the groups who should be offered PrEP. And in several HIV high burden countries are considering or are launching programmatic PrEP delivery for pregnant women, including where much of our team's work is conducted in Kenya, which actually even includes pregnant women in its national PrEP guidelines. With support from PEPFAR and a Dreams Innovation Challenge grant, our team, which Kenneth Mugwanya was a part of, conducted a demonstration project that showed that it was possible to deliver PrEP in maternal child health clinics and in family planning clinical settings. And the PrEP implementation for young women and adolescents, or PRIA program, provided real-world evidence on delivering PrEP to young women integrated within 16 routine maternal child health clinics in Kisumu, Kenya. And PRIA's approach was to integrate HIV behavioral risk assessment and PrEP services directly into antenatal and postnatal care. So this means that women were counseled on PrEP, and if they would like to initiate, they received PrEP pills directly from the clinic where they received their antenatal and postnatal care, often from the same nurse. And here are PRIA nurses, Christine, Joyce, and Veronica on the left, and Rose on the right. And these are all nurses who provide routine maternal child health services while also counseling and initiating pregnant and postpartum women on PrEP. PRIA was also engaged in raising awareness about PrEP in the community. And here are PRIA nurses Tony, Pauline, Emma Joy, and Yvonne carrying a banner through Kisumu that says, "Ask me about PrEP," during a World AIDS Day march. And PRIA nurses served in a role as PrEP ambassadors. PRIA also had a facility mentorship program where healthcare workers were taught about PrEP and why it's important to offer PrEP to pregnant clients. And there in the back is our project director, Felix, presenting a slideshow for healthcare workers. And these were well-attended sessions, often the first forum that healthcare workers had to raise concerns about incorporating PrEP into their practice. And in the PRIA program, among over 9,000 women who were screened for PrEP, over 20% initiated. And this is a photo again of Christine, one of the PRIA nurses. And these findings of nurse-facilitated PrEP delivery integrated within maternal child health and family planning settings were published in Lancet HIV and PLOS Medicine, if you're interested in learning more. But the PRIA program left us with questions about how to scale PrEP in the context of maternal child health systems. Specifically, it's unclear how best to deliver PrEP and identify women who could most benefit from PrEP in the busy MCH clinic setting. And we were particularly interested in whether offering standardized counseling about PrEP to all women was best, or would it be better to systematically assess risk and only offer PrEP to those determined to be at highest risk. So this was the primary research question of the PrEP implementation for mothers and antenatal care, or PrIMA study, which was a cluster randomized trial that sought to determine the best model for PrEP delivery during pregnancy in maternal child health clinics. And this trial was implemented in 20 facilities in Siaya and Homa Bay counties, 10 per arm, and up to 250 women were enrolled in pregnancy per facility and followed up through 9 months postpartum. And the primary study outcomes were HIV incidence and appropriate PrEP use. And here is the CFAR famous legend, Julia Dettinger, with study coordinator Ben Ochieng during the draw for facility randomization assignments. This was a few years ago now, I think 2018 or 2017. And the universal arm, general counseling was provided to all pregnant women, giving reasons to consider PrEP, and after which women would decide whether or not to initiate PrEP. And this approach may decrease stigma, but may also lead to over or underuse of PrEP, depending on how clearly women understand their own risk following this general counseling. And the targeted arm, a risk-guided approach was used that utilized a validated risk score developed specifically for Kenyan pregnant women to guide offer of PrEP and HIV self-test for male partners. Now, this approach could lead to improved risk perception and clearer decision-making about PrEP use or PrEP continuation, but could also potentially lead to increased stigma due to differential counseling time among this subset of women who are identified as high risk. And we hypothesize that women may not perceive their own HIV risk and that targeted PrEP delivery would result in better alignment of HIV risk and PrEP acceptance, resulting in lower HIV incidence and more appropriate PrEP use decisions. 20 clusters were randomized 1-to-1 to universal and targeted arms. 4,447 women across both arms were enrolled, and among those, only 2 women were medically ineligible for PrEP. And overall retention at 9 months was 94%. And I highlight this because it's just such an achievement from the study staff to have nearly perfect retention in a study conducted in a real world, busy maternal child healthcare setting during healthcare worker strikes, the ongoing pandemic, and many other challenges. It's really a phenomenal team. Median age was 24 years and median gestational age at enrollment was 24 overall. 27% of women in the universal arm were categorized as high risk using the validated risk score, and 47% in the targeted arm were categorized as high risk with the risk score. PrEP acceptance among pregnant women was 20% in the universal arm and 18% in the targeted arm. And by PrEP acceptance, we mean they left the clinic with PrEP pills. And any PrEP use, meaning self-report of swallowing PrEP pills, was 18% and 15% in the universal and targeted arms respectively. And these outcomes did not differ by arm statistically. Appropriate PrEP decision use also did not differ by arm. 68% of women in the universal arm had appropriate PrEP use, and 59% of women in the targeted arm had appropriate PrEP use. And the breakdown of PrEP use decision categories are displayed here in these pie charts. And among women who initiated PrEP, the proportion of women who were still on PrEP at 9 months postpartum and median duration of PrEP use were similar between the 2 arms. And HIV incidence also did not differ by arms. I mentioned earlier that in the targeted arm, HIV self-tests were also offered for secondary distribution to male partners, since knowledge of male partner HIV status is a key predictor of both HIV acquisition in pregnancy and also a predictor of PrEP use. And when offered both HIV self-test and PrEP at enrollment, half of the women accepted HIV self-test only, 14% accepted both HIV self-tests and PrEP, 10% accepted PrEP only, and 26% declined all interventions. And of the women who accepted HIV self-tests, 81% subsequently reported that they offered the self-test to their partners, with more than 2/3 reporting that they actually tested together with their partners. 69% of high risk or pregnant women with high HIV risk became newly aware of their partner's HIV status due to the HIV self-test distribution. And women who accepted HIV self-tests at enrollment were less likely to accept PrEP. We also evaluated infant outcomes in PrIMA. There were no differences between arms in the various perinatal outcomes that we assessed. And there are also no differences in perinatal outcomes between pregnancies with and without PrEP exposure, which is displayed on this figure here, including pregnancy loss, stillbirth, preterm birth, congenital malformations, low birth weight, and small for gestational age. Our team is also conducting an extension cohort study among a subset of PrIMA participants, which will evaluate infant PrEP exposure during pregnancy and breastfeeding. For aim 1 of that study, we will analyze tenofovir concentrations in paired mother-infant hair samples collected as close to birth as possible to quantify in utero PrEP exposure, and also analyze paired hair samples throughout postpartum to characterize the mother to infant PrEP transfer and exposure over time. We will also follow these mother-infant pairs through 5 years of the infant's life to evaluate longer-term infant outcomes following PrEP exposure in utero and via breast milk. And those outcomes include bone development, neurocognitive outcomes, growth, hospitalizations, many things. And here's a photo of our study staff, Joanna and Pauline, practicing hair collection. And this is what our hair samples actually look like. So please stay tuned for further results. We have an abstract under review at IAS right now with preliminary results on early childhood growth and neurocognitive outcomes in this cohort. So what did we learn from PrIMA? Well, appropriate PrEP decision and 9-month continuation was similar between arms. HIV incidence was also similar between arms. Pregnant women at risk for HIV initiated and frequently sustained PrEP use during pregnancy until 9 months postpartum. We also learned that incorporating HIV self-test distribution with PrEP increases awareness of male partner HIV status and can allow women to make more informed PrEP decisions. So based on our results, we recommend universal PrEP counseling to all women presenting for ANC and HIV high burden settings, after which they can self-select to use PrEP. And this is an optimal way for integrating PrEP in MCH systems and can be readily scaled in regions with high HIV prevalence. And this photo here is of one of our study nurses named Levine. And she modeled for our educational materials, which are part of a training module on PrEP for MCH nurses developed as part of the PRIA program, which are available on PRIA's website, which is linked here, for others that are interested in training up nurses to deliver PrEP in MCH clinics. And for my last few minutes here, I'm going to tell you about an exciting pilot which our team conducted recently, which integrated point-of-care chlamydia and gonorrhea testing into an antenatal care clinic offering PrEP. So incorporating testing for sexually transmitted infections into antenatal care could increase HIV risk perception and potentially motivation for PrEP initiation. Additionally, WHO and ministries of health recommend molecular STI testing in antenatal care due to the association of chlamydia and gonorrhea infections with pregnancy and fetal loss, preterm birth, small for gestational age, and other adverse outcomes. So from December 2020 to August 2021, we piloted integrating chlamydia and gonorrhea testing and expedited partner therapy, known as EPT, at one antenatal care clinic, which was a prior PrIMA site. HIV negative ANC clients who were over the age of 15 years were counseled on and offered expert chlamydia and gonorrhea testing with instructions on vaginal swab collection, self-collection. If participants were uncomfortable with self-collection, nurses collected the swabs. And after swab collection, participants received antenatal care services while specimens were analyzed. And chlamydia and gonorrhea results were then returned to nurses who counseled participants on the results prior to offering PrEP. Women diagnosed with chlamydia or gonorrhea were offered immediate supervised treatment per national guidelines and EPT with appropriate medication for their partners. And if participants declined the gonorrhea and chlamydia testing, they just received routine antenatal care services as usual, and that also included PrEP risk assessment and PrEP offer. In total, 300 HIV negative antenatal care clients were enrolled at a median gestational age of 24 weeks. Overall, 82% of participants accepted chlamydia and gonorrhea testing. And we did not detect differences between participants who accepted versus declined testing, except in the frequency of STI symptoms. And among participants who declined testing, the most frequent reasons for declining testing were not having time to wait the 90 minutes to get the results and feeling like they did not have STIs. Among those who accepted testing, 93% opted to self-collect swabs, and 9% had chlamydia detecting. We did not detect any cases of gonorrhea in this pilot. And all participants received their chlamydia and gonorrhea results at their same visit. And among the participants with chlamydia detected, which was 23 women, all were treated immediately, and 61% accepted EPT. Reasons for declining EPT included partners residing far away, so they weren't going to see their partner to give them the medications, and also fear of partner reactions. But among the women who accepted EPT, there were no adverse events occurring following that EPT acceptance. PrEP acceptance was significantly higher among women who accepted chlamydia and gonorrhea testing compared to those who declined, at 25% versus 11%. And we also conducted in-depth interviews with 50 participants to understand experiences with chlamydia and gonorrhea testing and EPT within ANC and the reasons for accepting or declining those services. quality of STI counseling provided by nurses, and the desire to keep babies safe from STIs were key motivators for testing. Participants understood the rationale and value of EPT to prevent reinfection, as illustrated by this quote from a participant here. I took it to him because there's no need of treating myself if he doesn't get the treatment. He will still have the disease and still bring it to me. And that is why I decided to take EPT so that we can heal together. So in summary, in this pilot, offering both chlamydia and gonorrhea testing and PrEP integrated within ANC was feasible. HIV negative pregnant women frequently accepted chlamydia and gonorrhea testing and PrEP. And if chlamydia was detected, frequently accepted EPT. So our results are similar to pilot studies in other countries, which also demonstrate high acceptability and feasibility of this approach of expert chlamydia and gonorrhea testing in ANC. But future studies in HIV high burden settings are needed to test the effect of universal chlamydia and gonorrhea testing on perinatal outcomes, and also assessing the implementation and cost outcomes of this approach in routine ANC. There are several other related NIH-funded research studies that our team has conducted that are super exciting, but we could not include them all in today's discussion due to time. But these studies include using an mHealth intervention to optimize adherence PrEP adherence during pregnancy and postpartum, using standardized patient actors to improve PrEP care among providers in MCH clinics, evaluating community pharmacies as a PrEP access point for pregnant women, and using implementation science strategies to optimize PrEP delivery within MCH systems. So we hope to develop studies further to understand how to scale PrEP delivery in pregnancy and lactation more widely throughout Kenya and to regional neighbors in East and Southern Africa. Now, this is the most important slide. There are a lot of people to acknowledge as being critical to this work, including all the participants in these studies, the amazing team members, the very supportive Kenya Ministry of Health partners, and of course, funding from NIH and PEPFAR. And I want to personally thank my mentors and CFAR and my CFAR mentors, Drs. Grace John Stewart, formerly Dr. Jared Baden, Dr. Renee Heffron, and many others that have allowed me to grow up scientifically here. So now please ask me lots of questions and I'll stop sharing slides.
Fantastic. This is excellent work and congratulations on all that achievement. We do already have one question in the chat, so I'll jump straight to that and then we can also get other questions from other people in the audience. This comes from Connie, says, great work, Jillian. First question, how did you measure HIV self-testing use with secondary distribution? Self-report from the women? Do you have data on the linkage to PrEP if men tested negative and ART if they tested positive?
That's such a good question, Connie. And I know that we've talked about this together before of how we could improve ascertainment of the male partner outcomes. And really, male partner outcomes overall in all of our studies are very much a challenge. And so to answer your question directly, in PrIMA, we relied on self-report from the participants in our study, so the pregnant and postpartum women. We did try to ascertain the linkage to care as much as possible when partners were reported to have tested positive, which was very, very few. It was just a handful. I'm not sure if Julia and Loren, they probably know the number off the top of their head, but we had sort of a separate spreadsheet where the field team really tried to track down what happened to those male partners, but the male partners were not part of this study. So we didn't actually include the male partners in our focus groups or any kind of, direct report of what happened to the self-test. But actually, it would be great to hear from others if there's been an approach where engaging the male partners directly to ascertain some outcomes from HIV self-testing or even EPT, innovative approaches that we could use in our planned studies to make that a more robust data collection procedure.
Great, thank you. We have another question from Dr. Patel. Says, fantastic work, is such a fan of your work. And she says she noted that PrEP acceptance among those at high risk was lower in the integrated versus the universal group in PrIMA. Can you comment further why that would be? Seems counterintuitive.
Yeah, it was not significantly lower. I can even go back on the slide to check, but we were also, I mean, not surprised, but somewhat surprised that PrEP uptake appeared to be similar in the universal and targeted arm. So I'm not sure if I'm answering your question correctly, Rena, so please feel free to clarify if I've missed the mark.
Excellent. We have a few minutes. We can take extra questions.
Kenneth, you unmuted me, but you didn't allow me to speak. Oh, I'm so
no, you are using a cheat code. I didn't, but I give you the opportunity. Please go ahead.
No, Jillian asked me a question, so can I just respond?
Yes, please.
First of all, I just loved that last slide where you just showed it all together. That was a great example of layering, you know, sort of just developing a suite of studies to answer complementary questions, and that is fantastic. But so that Kenneth won't mute me before I answer your question. So we, Andrew Mujigiro presented at CROI a poster, and I'd be happy to send it to you, that showed the results of our study called ABUMU, and they always tell me I don't say the B right, so I'm apologizing. Kenneth, stop laughing. Anyway, ABUMU. Anyway, the question is that we did that in our study where we were randomizing pregnant women living with HIV and Kampala to either secondary distribution as HIV self-test kits or the standard of care invitation for fast-track testing. And it's tough to ascertain the male outcome. So what we did is the women were trained to use it, given the self-test kits, and then counseled about how to approach their male partners. Not trivial, where you have a lot to lose if you have inadvertent disclosure or you get tossed out on your, you know, basically while you're pregnant or postpartum. And I think what we learned is that we told them in both arms, have your male partner come in for testing. And in the end, we had to call the men to try to get them to come in. And we hired a male counselor. And in the end, we probably drove the outcome towards the null because we intervened in the standard care arm and we got about roughly 43, 44% uptake of testing. Maybe it was 45, but it was not different in the two arms. So it's really tough, but I think probably the important thing is that was a way to really, we got 85, 90% of the men who were tested HIV positive linked to ART. And we had close to 60% of the HIV negative men on PrEP. So we should talk more because I feel like we're trying to write the paper now and I don't think it's a failure. It's just that you have a choice to make, you know, and we in the end felt like since we really wanted to look at linkage to care and PrEP, that the only way to do it is to have the men, not just to rely on the women. And certainly, I think the other thing we learned is for pregnant women living with HIV, there's a lot at risk. And it was not an immediate, like, yeah, come back for your first visit after enrollment, and they've done it. It took multiple sessions to counsel them. So thank you for your great work. That was fantastic. And thank you, Kenneth, for not muting me.
Thank you, Connie and Jillian. I think we'll come to the end of this session. I want to really thank Jillian for this fantastic presentation. I want to